I'm John Howington. I'm a thoracic surgeon in Evanston, Illinois. Prior to that, I was at the University of Cincinnati. The National Lung Screening Trial, we just talked about this, was highly effective. It is now the law of the land that we should be screening these folks. The trouble is what to do with these nodules. And in my practice, it's not just the screened patients, but as we mentioned, those patients that have an incidental finding of a nodule on a CT, and it's probably 3 to 1 patients have an incidental versus a screened nodule. And the concerns, and having just come from the CHEST meeting in Austin, there's still people on the podium talking about the dangers of thoracic surgeons and doing unnecessary operations on patients with small pulmonary nodules, and the excessive radiation for having to do repeated scans on these folks. So you have 3 choices when you have a screen detected or an incidental lung nodule: observe it, which is usually in some interval CT scanning; diagnostic testing, which would be a PET or navigational bronchoscopy, or a transthoracic needle biopsy, or a surgical excision. So in the ICAP, interestingly enough, Rich mentioned that they had an algorithm, as you see here, and essentially in their algorithm, nodules that were 4 millimeters or smaller were followed. They just got a scan in 1 year. In the NLST, if you had a 4 millimeter nodule, you got a 3-month CT scan. So that added to why they had a 28% positive test rate. 5 to 10 millimeters were scanned in 3 months, and if there wasn't growth, then they went to 9 months and then annual. And those that were over a centimeter, if they were investigated further. So this is Rob Flores and Nasser Al-Torki and the group working with ICAP looked at within the 31,000 plus patients that were in ICAP between 1993 and 2011, how many actually got a surgical resection. So were there excessive numbers of resections, and were there a lot of benign nodules being removed, and what were the outcomes from those, and was there a change over time, specifically between 1993 and 2005 before NLST, and then 2006 and 2011 after NLST. And you'll see here a minority of patients had a surgical resection. And one of the criticisms of ICAP, it was not so structured like NLST. All the only criteria for ICAP was you medically could tolerate treatment if you identified a lung cancer, and that you had an algorithm for screening that you followed. They didn't dictate the smoking pack years or the age. So the youngest person in the group was 40, the oldest was 85, in varying amounts of smoking and how long they'd quit. 89% of the diagnosed nodules removed or surgical resections, so nearly 9 out of 10 did have cancer. 9 of them were carcinoids. The estimated cure rate for those 428 patients with lung cancer, not carcinoids, was 84%. And 88% if it was resected in 1 month, and there's going to be a paper discussed later today in the scientific session covering that in detail, so I won't go into it here. The estimated cure rate for pathologic stage 1 cancers that were 10 millimeters or smaller, 95%. That's over 100 patients. So think about that when you're having a conversation with your patients. If you've done a resection on a 10 millimeter or smaller lung cancer and they're node negative, that's a patient I see back in a year, and I'm telling them, you're good to go. You have a very low risk. It's a different conversation. It was 83%, which is better than those numbers Rich showed in general, if you had a stage 1 cancer, even if it was 21 to 30 millimeters. So again, finding these cancers early when they're asymptomatic, you can have a significant impact. Among the 54 patients with non-malignant disease, the majority, 48, had a sublobar resection, and most of those were wedge resections. The concerning thing still for me is even between 2006 and 2011, 12 patients had a thoracotomy. And even if you say that the 2 lobectomies and segmentectomies were about thoracotomy, that's still 9 people that had a big whack to wedge out a benign lung nodule. So it's been my goal in my career not to make everybody do thoracoscopic lobectomy, but at least to do a thoracoscopic wedge before you identify a lung cancer. The Fleischner guidelines. So we do have some evidence, not just from ICAP, but also from our radiology colleagues, that when, unlike an NLST, with a nodule 4 millimeters or smaller, there's a very low risk, even in a high-risk population, that's a lung cancer. They don't need a short-interval CT scan. You can just get a scan in a year. I don't know why they use it, but essentially for 5 and 6 millimeter nodules rather than greater than 4, because my radiologists at least don't call it a 4.2 millimeter nodule. They usually say 4 or 5 millimeter. But those patients can get a CT scan in 6 to 12 months. And in our center, we do it at 6 months rather than 3 months for those smaller lesions, because you're unlikely to see significant growth in 3 months. And then for the 6 to 8 millimeter nodules, you get a 3-month scan if it hadn't changed, and you get one at 9 months later, and then a year. You'll see from this and from ICAP, anything that's 8 millimeters or smaller, you're not acting on. You're not getting a PET. You're not doing a navigational bronch. You're just observing those patients. And if you do that, it takes some of the angst out of it, and hopefully our family practice colleagues, when they get this message, will be less concerned. Looking at their data, so Claudia Hinchke's and others looked at 21,000 participants between 2006 and 2010. So if you look at those numbers, it really has exploded since National Lung Screening Trial. They did 31,000 and change since 1993 and 21,000 since 2006. So there are a lot of people getting screened today. And they asked the question, what if we change what is a threshold? And rather than saying currently if you have a 5 millimeter nodule, you need a CT scan in 3 months. What if we say that it was larger? So they looked at the frequency of positive results in the baseline round using the current definition, and they said, okay, if we left it at that, 16% positive in their cohort. And when they applied this in a separate paper to the NLST, it was similarly 16%, not 28%. But what if you used 6 millimeters as a positive test and said that anybody with a 5 millimeter or smaller nodule, that's background noise, I'll see you in a year? Well, with that, then you only had 10% of patients, so 1 in 10 had a positive study that needed additional testing. And if you made it 7 millimeters, then it was 7%, and you can see the other numbers. And that reduced the workup by a third if you just went to a 6 millimeter nodule being a positive test. What did that happen about cancer? Well, specifically in the ICAP, they had no 5 millimeter nodules that grew within the first year. So it was a 0% delay in diagnosis in their cohort. Now, when they applied this to the NLS2 trial, there were 2 patients, so a 0.9% 9-month delay in diagnosis. And the way you get to 9 months is if normally you would have done a CT scan in 3 months, but instead you do it in a year, you've delayed it. It seems intuitive that it's unlikely you've impacted lung cancer survival on a 5 millimeter nodule that grew in that first year. So if you set your threshold for a positive test to 6 millimeters or larger, that's going to be a 10% positive test result. So suddenly it gets a lot easier to manage these patients. You're not having to get repeated studies and following all this without delayed diagnosis. They've also suggested, and we are entertaining the idea of pushing the threshold to 7 or 8 millimeters in a prospective fashion. Just can tell you that even in a histoplasma belt in Cincinnati where 60% of patients had at least one nodule, you can screen patients and not do a lot of biopsies. Essentially in that trial, we did no wedges for benign lung nodules, but you can have a low rate of surgical intervention for benign disease. Thank you.